So the next panel is going to discuss improving equitable access to pharmaceuticals, obviously a very important question to round out the day. The moderator is Ali Tirani, principal at Real World Solutions at IQVIA. Had trouble with that one this morning too.
No worries.
And we have, to end the day, an all-star panel joining him. We have Angelique Berg, Chief Executive Officer at the Canadian Association for Pharmacy Distribution Management, Tobi Mitchell, Director of Health, Chiefs of Ontario, and Dr. Anne Snowden, Scientific Director and CEO of SCANH, the Supply Chain Advancement Network in Health. Have a good chat.
No? Okay, mic is not on. Oh, it's on now, right? Okay, great. So last panel of the day, guys. I know you're looking forward to cocktails, so we'll try to make it quick and painless. So my name is Ali Tirani. I'm principal of market access in IQVIA Canada and Real World Solutions. Our team focuses on solving problems in access, value, and outcomes in the Canadian context. My team specifically helps our clients navigate through the complexities of the Canadian landscape in terms of access. So, we've heard many times today how complicated the Canadian landscape is, and it involves multiple players and interested parties. Traditionally, we think of regulatory, HTA, payers, PCPA, but as you'll see today, access goes well beyond those parties. We're talking about physical access to medication for the patients that need them. If we take a step back and think of Canada in the international context, we do lag behind other countries, G7 countries, in terms of the number of launches and the time to launch. That's been mentioned several times today. And within Canada, there is disparity. At IQVIA, we track products through the market access journey at an indication level, and we can see that the average time from NOC to first public listing is over 600 days. And that metric is even higher when we think of the coverage of at least 50% of the population or 80% of the population. And there is disparity within the provinces as well and across the provinces. We've talked about PEI today. We were seeing that in PEI, 23% of products that received NOC in 2022 have been listed. That number is much higher, and it's 44% in Quebec. And in terms of time to listing, the average for PEI over the past 10 years has been over 1,000 days. In Quebec has been just under 600 days. So lots of disparity across the provinces. And within each province, there's a lot of challenges. According to CIHI, 5.4 million Canadians over the age of 18 do not have access to primary care. So if we think of Nunavut, for example, only 42% of adults have access to primary care. At IQVIA, we've done several real-world studies looking at access and the challenges in access. In one study, we found that patients' access to prescribers and long-term care was very, very challenging based on the geography of where they lived in Ontario. In another study, we found that patients had to travel very, very long distances to get certain surgeries and transplants, even though the disease was much more prevalent in rural areas. So basically, those who were getting the surgeries that needed were living in urban areas more of higher income. Pharmaceutical distributors play a critical role in ensuring Canadians have reliable access to medications that they need. This includes distribution through multiple channels, mitigating shortages, meeting requirements for special handling, and so on. And this is especially important for providing access to medication in rural areas and to First Nations. However, there are lots of challenges that remain, and that's going to be the focus of our panel discussion today. So to start us off, I'm going to ask each of you to provide maybe an opening statement and sort of talk about the lay of the land as you see it today. How are medications reaching patients today, and how is it being funded? So Angelique, we can start with you.
Thanks, Ali. I'm Angelique Berg, President and CEO at CAPDM, and thrilled to be here today. I know that market access, I started my career in market access, so it's really exciting to be here. But what we're talking about today, what CAPDM's talking about today, is physical access to medications. So we try to make good on the promises that you open up. We bring medications directly to patients, and we arm the healthcare system and the healthcare providers with the tools of their trade so they can make Canadians well. At CAPDM, we were established in 1965, focused on distribution. So whether that is wholesale distributors, self-distributing retailers, specialty distributors, we're it. With their trading partners, our members form the supply chain that delivers medications to Canadians. Right now, how that happens is it comes from manufacturers, brand and generic manufacturers, through 3PL sometimes, into distributors, and then into the healthcare system, whether that is whatever points of dispensation that is. Distributors play a critical streamlining role between hundreds of manufacturers and over 12,500 points of dispensing across Canada, both in hospital, in pharmacy, and other community settings or institutions. And that critical role, without that, we're not getting drugs anywhere. It would be absolute mayhem, all distributors trying to deliver directly to those places. The challenge for us? Well, Canada's a really big nation. It is a 9.98 million square kilometer problem. We have a population of 40 million. 66% of those people are located within 100 kilometers of the American border, and those that aren't are scattered throughout the country to the point that if they were scattered equally, there would be 2 people per square kilometer. We have the geography. When we look at our January lows and July highs, there can be up to a 50-degree swing in temperatures. When we look at how to get there, we have 1.13 million 2-lane kilometer of roads, but only 40% of them are paved. So when we think about Canada, we're really, really big, mostly empty, mostly gravel roads, and we have incredible mood swings. And that is the essential problem. The next problem is the way that distributors are funded. Distributors are funded essentially based on the price of a drug. So it's a factor of the drug price. If, let's say, a drug is $10, distributors will get about 90 cents from that. $100, distributors will get about $2 from that. So because it's predicated on the price of the drug, the lower the drug price goes, the less it's available for distributors, which is a problem. Rather than being paid on the services provided, the percentage is linked to the price of the drug. It doesn't matter if we're delivering to downtown Ottawa or Moosonee, it's the same price. And that's the incredible challenge for distributors.
Thank you. Tobi?
Good afternoon. My name is Tobi Mitchell. I'm from Akwesasne Mohawk Territory, and I am the Director of Health for the Chiefs of Ontario. The Chiefs of Ontario is a political advocacy organization that services all 133 First Nations in Ontario. I think just building off of what Angelique has stated, about the 40% of our roads being unpaved, or the other way around, sorry. When you look at First Nations communities, we have over 30 who are considered remote. They do not have any roads, whether paved or not. They are entirely dependent on the winter roads, which is, for those who are unaware, a big sheet of ice over the river and the land, and airplanes to fly in and out. And a lot of those times, these airplanes are very old. The communities often don't have the weather stations and the right equipment, or even the proper length of runway to expand or anything like that because of the lack of services and resources in our communities. So when you think about, physically a First Nations person in a community physically having medication in their hands, there are so many challenges and barriers that they face. Number one is, does their community have a doctor? Mm-hmm. Do they even have that in their community? Or do they have to call non-insured health benefits, which is the federal program that basically runs healthcare for First Nations and Inuit people outside of hospitals? To get medical transportation, to get someone from Moosonee to, say, Kingston for an MRI or something like that, you can wait months to get the travel approved and taken care of. And then a lot of times, NIHB is handled in major cities and they're not aware of the circumstances. So you can be in a community that doesn't have any kind of public transportation. You are completely reliant on the First Nations Band Council to get people to and from the airport to make their appointments, and the van breaks down. And that's out of your control, that's out of anyone's control, but non-insured will then penalize you 6 months. You will not be allowed to travel and rebook your appointment for at least 6 months, and that's if you can get back into your specialist and do all that all over again. So, when we talk about the barriers, the very first one that we see is the general access to someone who can prescribe that. Mm-hmm. That's not even then considering all of the things that Angelique just went into with the temperature swings and trying to get something from Toronto to KI, which is one of the 7 most northernest communities in Ontario. They are very well a remote community with a small fly-in airport, and their people go without services, without medication all the time because of the restrictions that are currently in place with the non-insured health benefits program, and trying to work around that and work within it to try and get community members and people the services and access to the same healthcare that those in Kingston get. I think that's really one of the big issues that we face is the reality of the two systems. There is the general Canadian public healthcare system and how that works, and then there is the First Nations, indigenous, Inuit, Métis healthcare system that does not work.
Well, with that,
My apologies.
no. I'm Anne Snowden. I'm the director and CEO of what we call SCANH Health. So this is a federally funded grant over 5 years for $2.5 million, which is wonderful from an academic view of the world. And we're trying to solve multi-billion-dollar challenge of supply chain of products in health systems. So access for me is access to the drug, as Tony and Angelique have identified, is just one very small part of a very large and very multi-dimension, I would say, complex system. Access to the drugs, if tomorrow, I'm going to take Angelique on it, I told her I'd do this and she said she'd forgive me, but if we fixed pricing tomorrow, just hypothetically, magically, the government says, yes, at any price, here's the approval, get the drugs to those who need them. Do you think the health system has the capacity to actually pull that off? And I would argue, not sure. Today, in any organization in this country, given our digital infrastructure and our supply of products to make it possible for, I'm a nurse by training, to deliver care, we don't know which Canadians are in any particular organization, emergency room, long-term care setting, etc. We don't have line of sight to what products they need. Are there care providers there to deliver those products? And we most definitely don't know what's working for whom and what's not working. We certainly know when we look at health data, our Indigenous communities do not fare as well, but we don't really have the data and the line of sight to, if you don't live in a major center with the Children's Hospital and the phenomenal genetics screening to know you have that rare disease, you're out of luck. So access for me is about outcomes. What are we achieving for whom? Who is prioritized at greatest risk? Do we know that? Because at least if we knew that, assuming we fix the pricing side of the house, you'd at least be able to take those very limited fiscal resources and prioritize them to who needs it most. It may start with our Indigenous communities. My guess is probably they'd be pretty high on that list, which would be fantastic. But until we really start asking those critical questions, do we have the products we need to deliver the care where and when and to whom it's needed, and that assumes people have access to that care, which we know is not the case, then I think we're just always going to be at these edges, tweaking the small bits and pieces and hoping for a new outcome. And I don't see it, to be honest. So for a panel at the end of the day, my thought is Canada's got to get its act together. We have phenomenal resources, and many of the speakers prior to us have identified those. One of the most highly educated populations in the world. If we can't figure this out, I got to ask the question, come on. So that's my challenge. Back to you, Ali.
Okay, well, you've touched on a few really important topics, so maybe I'll ask Angelique and Tobi for a response. Now, in terms of the Canadian policies and regulations, what are their impacts on what you're seeing in terms of the challenges?
So the policies that CAPDM is most concerned about right now and the distribution sector is most concerned about is PCPA. In 2007, when that first agreement was signed, it halved the revenue that distributors were getting. So they had no choice but to be incredibly creative and incredibly resourceful. They consolidated, they shut distribution centers, they streamlined everything they were doing. They went to automation. And they did that with quite good success. However, the challenge is that as things go along, you have a brand drug that comes in at $100, and then that's protected at a certain amount. And then all of a sudden the patent expires and now there's generics on the market and there's others coming in, flying in from overseas, right? And all of a sudden, distributors have to handle 3, 4, 5, 6 times the volume of medication for half the price or less. And that, the business end of that is really, really challenging. So that's the first thing. The second thing is Guide 0069 was an incredible advance. It governs, it's a Health Canada regulation, it governs the storage and transportation of medicines within temperature control. Not only do you have to pay attention to the label conditions, which of course distributors do, that's their everyday, but you have to prove that. So anybody who was subject to Guide 0069 had to put temperature loggers and maps and all kinds of things in their warehouses and in their facilities and in transportation in order to be able to prove temperature control from one end right to the other. And that's really, really important for the safety of drugs, particularly with specialty medications and things that could freeze when we go way up north or that are going to boil in the heat. The challenge with that is it's pretty hard to do when we get all the way up north, when we're getting out into the rural areas. So those two things, those two policies were incredibly important.
Thank you. Tobi, anything from your end?
I think for the work that I do in working with our communities, the non-insured health benefits program as a whole is the biggest government-run policy that impacts our healthcare outcomes. The program itself has 6 benefit areas: mental health, dental, pharmacy, medical supplies and equipment, medical transportation, and there is one more, you'll have to forgive me. It's been quite a bit since I worked in depth with the program. But we have seen it's been in existence since the late 70s, I believe, and at one point this program was kind of considered a Benefits Plus program. I actually got my braces funded through an IHB when I was a child, which you will be hard-pressed to find now. They have started to take a lot of things off of our benefits list, off of the DBL that is governed by Health Canada and ISC, and as I mentioned earlier, the issues with medical transportation and not being aware of what's going on in the communities. There's also the administrative barriers. This is something I brought up on the call, just an anecdote to show kind of how bureaucratic and how out of touch, I want to say, the system can sometimes be. I had a client at one point who had his leg amputated due to diabetes, which is a very, very common occurrence in our communities. It happens far too often. And I have to help this gentleman apply every year to non-insured to prove that his leg is still amputated. It did not grow back in order for him to get the stuff that he requires to take care of it. Yeah. That is a yearly occurrence. I'm not sure where in Canada someone was able to regrow a limb that this is a policy, but this is the reality that we face. And our people get discouraged when you're looking at what used to be your leg and being told that you have to prove to the government that it did not grow back in order to take care of yourself. So a lot of times those sheer instances that people are chuckling, and I chuckled after, I had some other words before that, strongly discourage our people from going and seek services. That's why you see a lot of times our people don't go get services until it's late. we're not diagnosed with cancer usually till it's stage 4, because the experiences that we have encountered, discourage us from seeking help. They make it show us we are a burden. We have to bug. Providers don't like working with the non-insured health benefits program. We know this. It's very administrative and cumbersome. They claw back money. We've seen providers go and have issues with the program just because they are trying to advocate for our people. And then what happens is they usually disenroll from the program and leave, because it's, they are a business, they have to keep their lights on, and when they are consistently being paid less than they are for other clients, you almost have to be charitable in signing up for non-insured. And so as an individual who's First Nations and knowing this healthcare system policy, I feel like we are relying on the charity of doctors and medical professionals to service our people, and I really don't think that should be the case. The way government puts up these barriers, it should be a lot more open and maybe encouraging in trying to get more services up there instead of putting those barriers up there. So for me, the non-insured health benefits program is it's the thorn in my side. It has been since I started this work in 2012, and it continues to be. We are working to try and get a review of the program done. We have been working for over a decade on that, so I don't entirely have too much hopes on a review coming anytime soon. But for those who weren't aware of it, that is the biggest barrier for us, and unfortunately it kind of is our only system for a lot of our community members. Thank you.
Thank you. But just to continue the conversation in terms of the indigenous communities, what about the access to pharmacies themselves? If you want to start, sure.
So a lot of times, a lot of our bigger communities will have pharmacies, sometimes run by the band, sometimes run with Northern Store. Sometimes we have our nursing centers who just have a nurse on standby who can and will dispense some medication. It really depends on the community, and the resources that they have, which again then comes back to geography. Are you up north where there's nothing, or are you in my community of Akwesasne, where we are right by the border? I sit on the international border, actually. So we have a pharmacy. We have a businessman who runs it, who comes in from Cornwall every day and commutes into the community, and it's a business, and he delivers to our community members, and it works out well for us. But we are not the typical scenario. We are a unique scenario, and because of our location, I think that is the only reason why we have some of the things that we do. It is that postal code lottery.
Yeah, postal code lottery.
Yeah.
Just to kind of pivot a little bit, what about the challenges of getting medications into hospitals? And we can start.
Challenge of getting medications into hospitals is a big question. Interestingly, Canada is when I compare it to other countries, very hospital-centric. We saw that in COVID. We have the very dubious distinction of 81% of our COVID deaths were in seniors in long-term care. The OECD average of percentage of seniors who died in COVID is 38, so more than double. So we tend to prioritize hospitals, but even with hospitals, when you engage with clinicians, and we spend a lot of time in our SCAN Health and looking at how do we solve disruptions and shortages. On average, pharmacists in both hospitals and communities share that they're managing 200 to 300 product shortages every week, and they're different every week. Many consumers and citizens are running into, well, I can't get my medication. They said I could take this alternative, but last time I tried that alternative, it didn't work. So shortages continue to be a challenge globally. We're very reliant on other countries. The 2% of the market does not position us well in terms of our influence. We saw that in Technicolor, in COVID as well. And we have a very bad habit of competing with each other. So not only are we very small, but when there's a supply shortage, every one of those 10 provinces and territories competes with all the other 9 provinces and territories to figure out who can get their hands on it quickly and fast enough. So there's no collaborative sit down, where are the shortages, Where do we have product? Where don't we have product? Who needs it most? Where are they? And how do we collectively move that product to where it's most needed? That requires everybody at the table, not just hospitals or provinces, but federal agencies, provinces, clinicians, communities, especially vulnerable communities, specialized communities that are not without the roads, et cetera, to make those decisions and work towards managing that disruption, and preferably proactively. Because when I talk to Angelique or any of the pharma companies and I ask them, what are you seeing alerts globally that we may be getting into a shortage? They all have them. Does anyone know what they are? Stockpiles, I've been asked about that a lot as well. Since COVID, everybody has a stockpile, or most people. Today, I cannot find one person in this country who can tell me where are the stockpiles, what's in them, and what inventory levels are in them. Some are at the provincial level, some are federal, some are organizational. No one has a clue. If no one has a clue, then you can pretty much bet they're not rotating that product through our health system, which means it'll expire in a fairly set period of time. So we've sort of bought the insurance, I guess, or the feeling that, oh, if we stockpile a whole bunch, we won't have this problem again. Well, there were provinces prior to COVID that had stockpiles. They burned through 3 to 4 months of stockpile in the first 4 days. So another issue, another problem, but I think we really have to rethink that supply confidence, build the confidence, think about it proactively, and it must have government, distributors, manufacturers, clinicians, who never know, by the way, until there's a shortage. They just get the call from the pharmacist that said, sorry, back ordered, can't give you that medication. At those tables, communities, particularly specialized communities, to make that decision, prioritize it. If we prioritize product distribution according to risk, we'd be much better chance of having an equitable system, as opposed to, well, if you live in downtown Toronto and you're lucky enough to be next door to St. Mike's or UHN, you're lucky. If you don't, oh well. That's sort of what it is today. Without overstating it, we have a lot of work to do.
Angelique, any perspectives on shortages?
Oh, I think we're our own worst enemy there. Quite frankly, Anne's right. The shortages have grown. Where it's caused the most consternation, excuse me, within the sector, is behind the scenes. So you have a whole bunch of distributors running around trying to find alternative product, and then it gets to pharmacy and hospital, and they're doing the same thing. So inside the system, that's where we've seen the biggest drain. Doesn't necessarily manifest itself at the patient level or at the clinician level. In some research, it's shown that there's very specific areas. Rare disease is a really important one that it does. But I think because we're our own worst enemies, we're doing this incredibly well. With 99% accuracy, we're showing that we're robust, that we're able to do this, that we're able to manage the shortages. And yet we're looking at a system that is got some vulnerabilities that we need to fix.
So changing gears a little bit, I want to talk about technology and how it's being leveraged to help access to pharmaceuticals and access to care. So Tobi, this question, we can start with you. How does technology play in terms of your communities? For example, telehealth, virtual health?
So telehealth and all that, I mean, the ideas are good. I get the concept behind it. The execution needs some work. I have visited many communities who have their telehealth equipment from Ontario sitting in a closet because they don't have the bandwidth. They simply do not have the internet strength and capabilities to run that. Not even looking at having IT support to come in and help install that and then run it. So at the basic core, you can see the disconnect between government and communities. Because government thought they did a real great job sending that out to every community, and I kind of laughed. It's going to sit, there's a handful of communities, but most of them up north, it will sit in a closet, and that is exactly what happened. I visited a couple, and they asked about it, and oh yeah, here, oh nope, it's all snowed in, we can't get there till spring. Like it just sits in the shed all winter. So that's in terms of the telehealth, and one of the other things that I was sharing earlier is, again, with the NIHB program and being reluctant to utilize technology, we still have to fax our medical records over to Ottawa. And, I don't know how secure fax machines are in a lot of buildings or who even still has them. But in our First Nations communities and band centers and health centers, it's not generally in a really well-guarded area. My band council, I could walk by the fax machine and it would just be running all day next to the reception's office. And that's how NIHB prefers us to send our medical records. They claim the internet is not secure enough. There are no ways for them to do it. They are waiting patiently on government IT list is the last thing I was told a few years ago. Because we see what insurance companies can do. You can submit online through an app and you can get approved instant. Non-insured, you can be waiting months and months to get an approval. And then that's even if they get all of your documents in the first try, because then they sit on someone's desk and that person goes on sick leave or goes away for a weekend and it gets lost. And I've had to send the same medical records for the same client in the same application over 3 times before it was finally approved. And that was an extra delay of about 6 months, I would say, in total to get someone their medication and their supplies that they needed. So the concept, and I see how it can help, but I do think government really kind of jumped the gun a little bit and needs to look at the basic infrastructure, such as stable internet. I have Starlink. It has given me more trouble lately than I care to admit. So we had communities who jumped on that bandwagon and are still not where they need to be as well. Thank you.
And anything from your-
Technology is a great question, and I think the whole and telehealth is just one great example. The digital infrastructure of the health system is really, in my mind, one of the very critical questions. If I went to an emergency room at St. Mike's Hospital today, and I was referred to a specialist at Mount Sinai a few hours later, they'd have to print my chart out for me to physically carry it over to the other hospital because there's no flow of data. When we measure digital maturity in many provinces and organizations, the majority of our hospitals in Canada, and this is not unlike other countries, are at a maturity level of 0. What that means is, yes, they have an electronic medical record, but the data in the electronic medical record, it does not connect to or integrated with the pharmacy data, not connected to the lab data, not connected to the imaging data. So as a nurse, I walk into an emergency room trying to figure out who has seen this patient, what labs do they have, when was the last time they had a chest x-ray. I'm going in and out of 4, 5, 6, 7 softwares to figure that out. We don't have that many nurses to do that. We have a tremendous shortage, actually, and often you just don't have time. So digital infrastructure here really matters. If we had a mature system, you would actually be able to track as an industry who's on these medications and what outcomes are they achieving or not. And that's the real world evidence we need to inform the next generation of those therapies and medicines, particularly when the numbers are small in rare diseases. So our digital maturity has a long way to go. Our flow of data is almost non-existent, particularly between provinces. During the COVID research, I ran case studies on supply chain capacity in 10 provinces. I spent 1.5 years trying to get just the COVID case data so I could map it to whether their shortages was driving outcomes. Never got the data. Doesn't exist. Well, it exists. I never got access to the data because that's the other issue we have is jurisdictional culture. Well, you can't have my data. You don't live in Ontario, so therefore you can't have it. Or you're not Albertan. If you're Alberta academic, we might give it to you. So we have this weirdness in Canada that data doesn't flow, data sharing doesn't happen, and in many cases the digital infrastructure wouldn't allow it if it did. And that's just one small piece of the reporting to get approval on anything. If you don't have the digital infrastructure to know what the imaging or what the diagnosis was or the plan is, and you're going to fax it, and yeah, it's not secure. It sits on someone's desk. You could read through any number of those cases if you wish to, weirdly. So digital infrastructure is a very, very significant challenge and is precluding us from having the real-world data. I think industry and manufacturers really need to know where is the next generation of products that are needed by
Just on that as
population.
well, I just came back from a conference, the International Federation for Pharmaceutical Wholesalers, and at that conference, we had Europeans there and US and Japanese were there. They were asleep, but they were there. And everyone was in this room comparing where we were. The Europeans and the US, they're at full serialization. They can do recalls that are just incredible. They can do lots, dates, everything. They can do it all. In Canada, we're still wringing our hands about putting 2D data matrix barcodes on packaging. I kind of went like this. We're so far behind, and yet there's such opportunity to close the gaps, to get those things done so we can share the data. We're small. We can do this, but we have to have that collaboration right across the supply chain and into the clinical network so that we can do it.
Thank you. I'm just cognizant of time, and I want to leave some room for questions from the audience. So what does the future look like? It's a loaded question,
Tobi,
right?
let's start with you.
Yeah. No, because we've talked about system readiness. There are lots of drugs coming down the pipe. Are we ready for that? What does the future look like? Really?
So what does it look like if we do nothing, you mean? Or what could it look
well,
like?
both,
Okay.
right? Both. We can end on a positive note.
Okay. Canada, and you've all identified this already today, Canada holds an awful lot of cards to be able to lead in so many areas. The researchers are outstanding. We have phenomenal R&D infrastructure. When I started my comment, and my offhand comment, didn't mean to, but we just have to get our act together. We can't wait for government to make all the policy decisions so all will be good. I think we've been doing that since, for a number of decades, I've been paying attention anyway. It takes the trust and the time to sit down with the private sector has the technology and the expertise. The governments will never have, and the health systems don't have either. But they all, when you bring those respective expertise, those clinicians, patients, communities with very unique and special needs, manufacturing, distribution, and we've done that, the community of practice, put them all at a table for the whole first year of this community of practice. I'm in year 3 now. The outcome was daily. I had no idea they were doing this. I didn't know they could do that. So it was like a bit of a discovery. But we're beyond that. So it's like, okay, now that you all know what each other does, fabulous. Well, how do we fix it? How do you prioritize it and fix it and build those solutions? We do have solutions coming up, building on the expertise, many of which is sitting in this room. So it's possible and it's achievable. It's a heavy lift. So it's the motivation and the stubbornness, I think, to make it happen. And Canada tends to be more likely to sit back and say, oh, it's not a shame. We keep having the same conversations. The action plans I don't see as often as I like to, but the potential is better than anywhere in the world. We just have to decide to go after it.
Thank you. Angelique, anything from your perspective?
I think I shared what I thought, just the potential that we have. I think probably what I would love to see for the future isn't the answer that you'd expect me to give. I would love to see everybody vote. I'd love to see everybody go out and vote and be active citizens in your electorate. We get the government we deserve, and we all just have 3 things that the government says we're supposed to do. Just get out there and vote, serve on a jury, and maybe bear arms if we really go to war. But vote is probably the only thing that we're going to have to do a couple of times, right? Go and do it. Just take your kids and show them to do it. And let's really start to get an active electorate. We need to hold our MPs and our MPPs accountable. If we don't like the leader at the top, we tell our MP or our MPP. And we make sure that we're being active and engaged in using that democratic system. Because if we're not going to use it, we're going to lose it. And the way that we can get health issues on the agenda is to actively be citizens and be active electorates so we can actually do that. And that's what I would like to see.
Thank you. Tobi?
Well, I guess for me, that depends. I mean, for me, the future looks one of 2 different ways. There's one, the status quo, where the life expectancy gap continues to grow between First Nations and the general Canadian public. During COVID, it was 20 years in Alberta between a First Nations individual and a general Canadian person. To me, that is a status quo. If we continue down the road that we are going, that gap will only widen. The other one is, there's a saying that we have at Chiefs of Ontario, nothing about us without us.
Right.
So if we can if that can be embodied and, we start having these communities and marginalized people at these tables to really talk about the realities and, realistic solutions that can be fixed. Some of these problems are fairly simple fixes. It's just getting the will behind it. So for me, like the future is really, I'm looking at a crossroads here or a Y in the roads and trying to determine which way this country is going to go. I know which way I would like it to go, but we'll see about the leaders and everything else. I would, though, like to ask everyone to check out the Truth calls to action for the Truth and Reconciliation Commission. Call to action number 24. 18 to 24 are all related to health, and 24 specifically calls for all medical professionals to have a indigenous awareness course that they go through university to learn about all these things and to learn about the realities and just generally spread that awareness, because we find that is the biggest barrier is people don't know. And once they know, though, they generally want to help because people are generally good. I think that's just where the crossroads.
Thank you. Questions from the audience? Nothing? Okay, great. If there's no questions, then I think we can adjourn. Perfect. Thank you guys so much.